immune function, immune competent, intelligent for processing representing cells, a large pool of endocrine cells synthesize and produce in the GI tract for the GI tract, and large, almost parallel to CNS, enteric nervous system. To carry out its function, it has two interplay between the external environment and internal environment. So very complex interplay, the cellular communication between the GI tract, its cells, and the rest of the body. So they are all endocrine, autocrine, paracrine, functions and components inside this organ. So it's a complex system having the cellular, chemical, and the electrical component, just like neuron and the cardiovascular system. How this all functions are regulated. In fact, they are, because of the smooth muscle, they are automatism. The smooth muscle have their own functions. They can control their self. There is an intrinsic nervous system. Mind is an enteric nervous system, but the intrinsic nervous system, the cell bodies, dendrites, processes are unique to the GI tract. Superimpose on them, there is autonomic nervous system, sympathetic and parasympathetic. They control, modulate, and of course, there is control of higher centers. And during this process, there is not redundancy in higher. One system goes up, another system takes over. So it's a very complex interplay of all the systems, intrinsic, autonomic, cortical, and then self-autonomic. Enteric system is just to demonstrate that there are several types of unique cells which are unique to the GI tract. This cell, this cell is unique as the interstitial cell of Kazal, which is the pacemaker cell of the GI tract. You have the pacemaker in the heart, as well as you have the pacemaker in the stomach as well as the intestine. Because of that, so many components, endocrine, neural components, GI tract is easily involved by different systemic disorders, especially diabetes. But then because of redundancy, it is involved very late. In fact, if you see the diabetic patients, almost 2/3 will have some sort of GI symptoms, but of course they are the later stage. And these symptoms have negative impact on quality of life. People suffer and their quality of life is poor. And these symptoms have independent association. Independent association with the neuropathy, it's a hyperglycemia. So you cannot say whether it is hyperglycemia per se is in response to it or neuropathy per se is response to it. Both have their independent action on the GI system, which their components, reducing the pathology as well as symptomatology. Several symptoms are there. Constipation is one of the commonest, but you can have pain, nausea, vomiting, diarrhea. Single patient can have constipation, diarrhea, both. So, if you see GI tract involves esophagus, from the esophagus right up to the rectum. So we will take one by one of one organ. As I said, to understand GI motility disorder, you have to understand some physiology. Because pardon me, I'm giving you some very basic and very topic which is not interesting in the post-lunch session. Physiologically, we divide esophagus in three parts. Upper part, which is upper esophageal sphincter, and lower part sphincter, and between the body. Lower part of esophagus and sphincter is made up of pure smooth muscle cells. Upper esophageal sphincter is purely skeletal muscles, and in between there is a transition zone which is mixed both the type of cells. And to control esophageal function, there is basically deprivation. We have complex system in the brain. There is swelling center in the brainstem, which have sensory inputs by sensory nerves and efferent neurons. Will concentrate on the one cell, that is 10, the dorsal motor nucleus of vagus, which innervates the smooth muscle part of the esophagus. So basically different upper ends, sympathetic, parasympathetic, then there is a swallowing center, there are several efferents, and 10th nerve is the efferent which controls the esophagus body. You can see there is a complex system. Though esophagus is the least innervated of the GI tract, it is still so complex. Very simple, smooth muscles in the vagus are the excitatory cholinergic and inhibitory part is nitric muscle. And as the striated muscles are acetylcholine. Just like any other smooth or striated muscle in the body. And sympathetic nerves, again, the beta adrenergic is inhibitory, alpha is excitatory. They also modulate. But the basic control in GI tract, parasympathetic stimulates. They will cause more of secretion, more of peristalsis, and relaxes the sphincter. Sympathetic tones only modulates, and they are inhibitory. If you see how the swelling occurs, first in the voluntary phase, where you take up the food inside your mouth, voluntary propel the bolus into the esophagus, and once you propel the food, there is an upper esophageal sphincter which relaxes. You can see that pressure goes down, then there is peristalsis in the body, and this peristalsis in a very disciplined manner goes till the lower sphincter LES, where LES relaxes. There is a characteristic amplitude of velocity, we will not go into detail. We have the lower sphincter is tonically contracted. Neurogenic control, as I've already told, acetylcholine causes the contraction and nitric oxide causes inhibitory action on LES, lower sphincter. How is esophageal motility disorder disturbed? It's basically neuromuscular apparatus is disturbed. Either peristalsis is defective, either it is not forming, or there is abnormal peristalsis, or the sphincters are abnormal, either they are not relaxing, or they are hypo or hypertensive. So basically the contraction problem is there, and it causes the esophageal motility disorder. For investigating the esophageal motility disorder, you have to investigate two things. One is the transit, whatever food you are taking is going down or not, and then you have to assess the motility, contractions. Upper GI endoscopy has a role because it is basically to rule out mechanical problems. Because it's very important, if you miss motility disorder, patient's life is not at this stage. But if you miss mechanical problem, patient's life is at this stage. So upper GI endoscopy will not diagnose motility disorder, but it will rule out the mechanical disorders, needs urgent attention. You take the biopsy, it can do the palliative things. And the gold standard is manometry, where you put the sensors inside your esophagus, measure the pressure at the different level, then you can make out tracings, which can show you contraction, their amplitude, their velocity, how they are moving. Then you can also, by these methods, see the transit, and you can have sensory testing. Like with the problem in esophagus, you have the contraction abnormality, but symptoms are not there. When you have the symptoms, but there is no abnormality in esophagus. So you have provocative test. You infuse the saline, you infuse the acid inside the esophagus, and then you see the symptoms are generated or not. So you have the sensory testing, provocative tests. What happens in diabetes? If you see, if you do studies, up to 2/3 of patients with diabetes, especially with neuropathy, advanced stage, you can have this manometric abnormalities. Mind it, we are abnormality in research, which is present at the esophagus, but they may not be symptomatic. Majority are clinical exam. And abnormality with any form. Vessels may not be there, it will be abnormal wave pattern, it will be propagating abnormally, sphincters are not present. So all sort of abnormal defects are there, but majority of times, surprisingly, people are not symptomatic. And pathophysiology as we have, in all symptoms of GI tract, there are only two things they say. It is basically either because of autonomic neuropathy or hyperglycemia per se. Will lead to disturbances in neurons, endocrine system, the symptoms are there. And in symptoms of visual disorder remains as in the general population. They can heart burn, they can chest pain, they can dysphagia. The symptoms are not unique. Symptoms are just like any person who has having visual symptoms. Of course, visual reflux is more common because these patients are sometimes obese and they are also dysmotility. So how will you treat? Again, the symptoms are not different, pathophysiology may be different, but the treatment remains almost the same. Because the treatment, you are not going to correct the motility disorder, you are not going to correct the manometric abnormality. It is the symptoms you have to alleviate. And symptomatic, you can use PPI if you have heartburn symptoms. You can get a smooth muscle relaxation if there is dysphagia. Mind prokinetics sometimes may be counterproductive in these cases. If you do metoprolol or domperidone, they will increase ileus pressure. And sometimes this increased ileus pressure may be counterproductive. You want to relax the smooth muscles. So manometric abnormality, if you find out manometric abnormality, you can direct what is the type of treatment in the patient. Most of the time they require smooth muscle relaxation. And one of the non-cardiac chest pain, when you give the sorbitol, you relieve the non-cardiac chest pain, you superior quality, even if it can improve the chest pain of cardiac. The treatment remains almost the same. And if there are disability disorders, you can do a balloon myopathy, dilatation esophagus, and you can do long myopathies to relieve the dysphagia. But it depends what type of symptom, what type of abnormality in esophagus, and more so, what type of symptoms patient has. But not going to treat just because patient has abnormality on investigation. He has to have the symptom. Again, come to the stomach. It's physiologically, stomach is we can divide into three parts. One is the proximal stomach, which is basically for accommodation. As soon as food goes, it relaxes. It relaxes and accommodates the solid food without increasing the pressure or tension in the bowel. So it's basically receptive relaxation. And the middle part is abdomen body, basically produce the high amplitude contractions. Physiologically, pylorus and terminal part of antrum, pylorus and duodenum, we consider it a single organ because both causes the resistance to gastric emptying and it helps in the digestion. So this pyloroduodenal portion has a resistance. So whenever there is a antral contraction, whenever there is antral contraction, food comes into antral. Small particles will go down, and large particles are retained and they are propelled back, and this pressure will cause a saturation and mix. So now we can leave the physiology part, but the more important, gastric emptying basically contains food. What the calorie? Stomach delivers the calories, not the amount of food. 3 to 4 calories per minute. So calorie content of food is high, gastric emptying is low. The fat empties more, same calorie fat, same calorie carbohydrate fat, emptying is slow. Same calories solid and same calorie liquid empties fast. So it depends on the physical content, characteristic and the calorie content, what is going to deliver fast. So you can modify the treatment and diet as per the requirement. Hyperglycemia has an effect on this gastric motility. And it causes the delayed gastric emptying. What's time here, sir?
5 minutes, sir.
5 minutes. Just like in the animal, the heart, here also there is smooth muscles, there are slow waves, which are the pacemaker rotations. The stomach and proximal parts, there is a cells interstitial canal. They can be a pacemaker cells. They produce the peristalsis. And there is a problem with the interstitial canal. There will be problem with the peristalsis. The cells, neurons, smooth muscles, interplay will cause the vibration of peristalsis and then electrical activities. For assessment of GI motility, again there are 3 parts. You have to assess the emptying, you have to assess the pressure, and you have to assess the electrical activity. For the emptying, the scintigraphy is there. Where you assess how much activity is being passed through the stomach. There are methods. Then the second thing is you have to measure the contractile activity, just like you see with the ventroduodenal motility is there. And just like you see the electrogastrography is there. Where you have the slow wave frequency less than 2.5, it is known as bradygastria, just like bradycardia, and if it is more than 3%, it is tachycardia. So you have all the electrical abnormalities just like not in the stomach also. Diabetic patients have the gastric abnormality, the poor gastric emptying, which is known as gastroparesis, like diabetic gastroparesis. As is very clear, they are more present in the type 1, long-standing, poor glycemic control with neuropathy. The symptoms may be just like symptoms in the general population, may be normal, dyspeptic, bloating, nausea, and of course bezoar formation. And very important symptom, these patients, especially type 1 or insulin dependent, people will have poor glycemic control and recurrent hypoglycemia because of delayed gastric emptying. Liquid emptying is normal in these patients. So when you are modifying the diet, you can keep these physiological facts in your mind. How are we going to treat these patients? Of course, like in earlier, you have a pharmacological, endoscopic, surgical,